do something about it, right? So either they make themselves throw up, or they take a lot of laxatives to get rid of the food. Some people do a lot of exercise to burn it out, way over the top, right? But they're not doing it because they want to gain muscles or look great. Their preoccupation is the food they ate they thought was too much, so they're going to burn it or do something like that. So when your relationship with food has an issue, you might fall in any of these categories. But this dysmorphia also has to do with how you see yourself, right? There's some people that other people think are perfectly normal physically, but they see themselves totally different. Another thing you might hear out there is ADHD. Now, when you hear ADHD, everybody goes straight to the hyperactive type. We all know those people. They can't sit still. They move about. If you have to make them sit still, they fidget a lot. They're moving their legs and their fingers all over the place. So that's easy to notice. There are other types of ADHD that go unnoticed, right? One of them is the impulsive type. These people are very impatient. They hate waiting in line. They hate waiting for their turn. When they want to talk, if anybody else is talking, they don't care. They just start talking. And they blurt out things with little or no regards to the consequences of what they say. And the thing you always just tell you, right? The inattentive type. You hear them say ADD, right? Okay, these people forget a lot, all right? They get easily distracted. If you are always misplacing your keys or your pocketbook or your wallet, if you get easily distracted, like you're doing something, you get distracted by a second thing, and you forget to come back and finish the first thing. So you have all these leftover things. At the end of the day, you're feeling so overwhelmed because you started 10 different things and couldn't finish any, right? You walk into a room and you can't remember why you went there in the first place, right? So these are like some of them. Okay. I see some people laughing. I'm not telling that. Some of that might be normal, right? Due to aging and stuff, how many things you got to do, but some of it is not. That's why you need to go see one of us to figure out whether the one you are experiencing is normal or you need to do something about it. And then there's autism, right? So autism is one of those conditions that also impact how you think, how you feel, how you behave. But basically, it presents itself most of the time in social, it's a social development thing, a communication deficit sometimes. So they call it autism spectrum because it impacts so many things, and almost everybody that got autism presents a little bit different than the next, right? So that's why they call it a spectrum. You can get a little bit of this and too much of that, or a little bit of this other one and not this one, right? So why it might be good to be diagnosing yourself? It's always good to just go check it out, right? Some common myths about mental illness, right? Some people think mental illness is a weakness, right? They're all that person. They're always been lazy, right? Or like you have depression. Remember the definition was you have no desire to do those things, right? And then people say they're lazy. They don't want to do nothing, right? Okay, so it's a myth. These illnesses are serious. It's not because the person is lazy or they're weak, right? Another myth is they just need to make up their minds to do something, right? They just need to get up out of bed and do something. Now, if you don't have any energy, you don't have a desire to get out of bed, those things are gone. It's not like a sign of laziness, or it's not like you can make up your mind, right? Now, even if you have issues with your thought processes, and then somebody's telling you, make up your mind, it's like, that's where the problem is. I can't, my issue is I can't, right? So it's like telling somebody that got no shoes on, you gotta lift yourself up by your bootstring. It's like, I don't have boots on. So, another one is there's no treatment. That's why people are afraid of the diagnosis, because if you get diagnosed, that's true. Some of these
We are
disorders,
live in Conrad Boulevard.
so for
The
some of
phone
these
is like
disorders,
license.
you get stable, like what you think, it's stable for about a year.
Just tell them to leave it. Tell them to leave it. Only.
You need to get off it because whatever you're listening to, we're listening to.
Oh.
You know how we Google everything these days? This one. But even best yet, that's what this fair is about. When we get a break and we go to the gym where there are vendors, most of those vendors are providers, right? All the speakers here tonight are providers. I mean, this morning are also providers. They got business cards. Some of us even provide free consultation if you just want to check it out, right? I still for the vendors over there, which one of them can provide free consultations, right? Spirituality comes up, right? Some churches have trained therapists in the church. Some pastors are actually trained psychotherapists, right? So if you are one of those people that think your mental health and your church should be in the same place, actually it depends what resources are there in the church, right? Or whether they have those kind of people that are trained to do it, right? Also, if you are based, if your thought processes about mental health is more spirituality based, you should also consider us as one of the resources God provided for you, right? Because you're here and we're here, and it's available. All right, good question.
Good morning. Most of the still the depression and the eating too much, most of them connected to each other. Because some people eat when they're depressed. Some people go into the bipolar. When the bipolar is depressed, it's depression. And when you say that some people take the pills and afterwards they can get off it, don't mean to be disrespectful.
No.
But when I see all the killing with the kids in high school and the shooting and stuff, the kids that were taking these medication and they felt it was okay. So they stopped taking it. But then they don't believe they're sick anymore and you think they can get off it. Then when you see them doing the killing, people do the shooting, the police people, when the police go grab people, most of them got mental illness. So the thing is, I know a lot of it connect. But for you to get off your medication, I think you need to go to a doctor to tell you to get off. Because if you just keep on, okay, I'm gonna not take it for this amount of time, anything is snapping to your head. And that's where the problem comes in. For me, that's how I see it when I look at read on the newspaper and see the news, or all these people that got, because when they do killing or something, oh, they have mental illness, oh, it was mental illness, they were doing this. So I know a lot of the mental stuff connecting to depression.
All right. I hope you guys didn't get me wrong. I didn't say you can get off of the medication by yourself. I clearly said after you've been on the medication, you've been stable for a year, and you want to try getting off, go talking to your doctor. There are ways we can help you taper off the medication, but we will be monitoring you. So if you are my patient and you want to try getting off after you've been stable for a year, I see you more frequently within that period to see if any symptoms are coming back, right? I'll see you more frequently. And I don't want to get political about the shootings and all that stuff, but if the answer was as simple as that, there's a lot of us available to see those people before the shoot, right? So if that was actually the problem, then it shouldn't be a problem because there are a lot of us available. Yeah, you. So don't get off your medication without talking to your doctor or your doctor, whether it's diabetes or mental illness.
And all that you're doing. As a student of psychology, I've come to also realize that spirituality is also intertwined with all of what you have just told us. How do you demarcate and differentiate when it comes to the disorders that you get, especially deliverance and therapy, all those things, because the lines are so blurry and sometimes people can get confused. Thank you.
Yes, the lines are blurry and people do get confused. All right, so I say, if your thought about mental illnesses are more bent towards spirituality, number one, you need to talk to the resources in that church, right? Some pastors are trained as psychotherapists in their training for ministry, right? And some churches do have practicing psychotherapy on staff, right? I also said that treatment being available, can also be wrapped into your spirituality. Not every time people got healed in the Bible was by miracle. Read the Bible. There are times God sent them to a practitioner, right? Remember the guy with the leper, and he said, and I remember Paul when he got blind, and he said, go wait for that guy in the town to come. He knows how to get you to see. There are a lot of places in the Bible where God used resources that He's provided. And we ourselves are also resources that He has provided for Christians or however you find your spirituality. We are resources. Who you think gave the idea to the people that need the medication, right? Who you think gave the idea to some of us to go to school to learn how to do this thing, right? Or the strength. So we are resources. We don't come to mind religion, right? If you come to us, we do our assessment. Actually, one of the questions in the thinking has to do with spirituality. And if that's your bent, yeah, we'll talk to you from that end too, right? So there's no confusion between mental illness and the treatment for mental illness and your faith, right? You just see the treatment as the resources that were provided by whoever your higher power is. One more question I was told. She gets to decide on the last person. So, yeah, there'll also be more people, a whole panel sitting up there with more questions.
Thanks for having this conversation. I was just wondering, I have one question in mind, most especially within our African community. How do we go about talking about these issues concerning mental health within our community, or someone who has it, and needs help, but he's kind of afraid because of cultural sensitivity. He doesn't want to tell people and they're going to look down upon him. How do we start those conversations to help that person?
Well, we start the conversation like right now, right today. Before you leave, this event is being hosted by the Liberian Advanced Practice Network, right? So there are other practitioners from other African countries. When you say our culture, you're thinking about the African culture, right? So there is somebody that you should be able to feel comfortable to talk to. For example, if you came to me and that was a concern, I will reassure you. Sometimes all we have to do is even lock. There's a way we can lock your chart so that nobody else within the clinic system can go into it, right? So there are ways we can go around it. In the end, though, you will have to decide whether you want to live the rest of your life with a symptom that got treatment because you care what other people might think, or you want to be that person that will take treatment and still be proud that you got help. So there'll be panelists here today that will say, look at me, I got help and I'm okay, right? So you talk to somebody. That's how you do it. All right, I think that was the last one. Thank you for listening.
Before I introduce the guest speaker, we're gonna go around with rapid draw tickets. So just keep them at the end of the program. We'll have the opportunity to draw. In the middle of the class. Our next speaker is Dr. Alexander Ayaki. He's an MD in PH. We'll be talking about substance use disorder. Dr. Ayaki is world-certified psychiatrist and medical director of Diamond Lake Clinic in Minnesota. He is fellow of the American Psychiatric Association and a member of the Minnesota Psychiatric Society. He earned his medical degree from the University of Nigeria and a Master of Public Health from the University of Alabama at Birmingham. He completed his psychiatric residency at Hennepin County Medical Center with extensive experience in emergency psychiatry. Dr. Yankee previously served as medical director of IQ Psychiatry Services at HCMC and has taught at the University of Minnesota. His areas of expertise includes adult mental health and substance use disorder. We will welcome Dr.
Thank you very much for that introduction. I'm going to set this down because I have another microphone. Yeah, this works, right?
But that's for the recording.
Hello.
That's for the recording.
Oh,
But I
okay.
think just to see if people can hear you without it.
Can you hear me?
Yeah.
Okay, great. But you can send it. So welcome everyone, and thank you for taking the time this fine day to attend this event. I also want to thank the Liberia Advanced Practice Provider Network for putting this event together and for inviting me to speak about substance use disorder. I am the founder of Diamond Lake Clinic, just like the introduction said, and it's a growing mental health provider in the metro area. We have an office in South Minneapolis and a new office in St. Paul, where we provide mental health services to individuals with severe and persistent mental illness, as well as individuals with chemical dependency issues. This topic today, substance use disorder, is very timely because of the rising impacts of substance use disorder in the community and in the nation. Substance use disorder is the leading preventable cause of preventable and accidental death in the United States. My goals today will be to introduce substance use disorder, talk about the risk factors, the different types, the populations affected, and of course, the evidence-based therapeutic treatment of substance use disorder. So, substance use disorder is a mental illness that is characterized by persistent use of any substance despite negative consequences in our social, occupational, family functioning, or health. So what does that mean? It means that individuals can become hooked on any substance, they can misuse any substance, and they can, of course, get involved with illicit drugs. So prescription drugs fall under this. You know, many of us here have had trauma or pain, physical trauma now, and pain, and we've received prescription opioids from our providers, healthcare providers, and some people have gotten hooked on those drugs and have misused them, fall under this. Some people also have sought refuge after trauma or life events, and they've held on to alcohol and other substances to get relief, also substance use disorder. And some people, especially young children or teenagers and younger children who don't have access to street drugs or prescriptions, can abuse household chemicals such as paints and glue and all kinds of things to get it high. Also falls under this issue. So the big thing to know is that it's a mental illness, even though it's not treated as such. But I want us to remember that it's a mental illness and there's help. Common types of substance use disorders. So alcohol is by far the commonest substance use disorder. Tobacco use disorder is also one of them. And cannabis use disorder, we know that cannabis has been legalized in Minnesota. But just because a substance is legal doesn't mean it cannot cause harm. Because people do get hooked on that as well. Cocaine used to be a bigger problem in the past, but it continues to be a problem today, even though the incidence and prevalence has decreased. Opioids is a big one because, like I said earlier, many people use opioids as prescriptions from healthcare providers in primary care, in specialized care, in surgery to treat pain. But some people end up misusing them and develop substance use disorder. Also, there is heroin, which is not a prescription, but that people can find in the community and get hooked on. And lastly, there is fentanyl, which can be a prescription, although there is illicit fentanyl on the streets now and in the community, which people can also abuse, and that is one of the top killers of young people between the ages of 18 and 49 in the United States. Methamphetamine was also common recently, but the prevalence has decreased. And last but not least, we have polysubstance use disorder, which describes a condition where the individual has problems with the use of more than two substances. So maybe alcohol and cocaine, or opioids and methamphetamine, then we talk of polysubstance use disorder. So I said earlier that this is a timely topic because it's very important. And here we see that there are close to 49 million US residents who have reported enough symptoms and issues to meet criteria for substance use disorder in the last 12 months. This data is from CDC and it's current for 2023. We're still waiting on last year's data, but the trend has continued. So the prevalence of substance use disorder is about 17% of the population. So that's a big deal. We have alcohol use disorder, which is the commonest, probably because alcohol is easy to find. On our way here, I'm sure many of us drove by liquor stores, so people can access alcohol. It's it's legal, but it can be misused. Hence, we have substance use disorder. And drug use disorders account for about 27 million people in the United States, and that covers some of the drugs I mentioned before. So methamphetamine, cocaine, fentanyl, and other drugs. And polysubstance use disorder is made up of about 8 million people in the United States. And these are people who have, like I said, used alcohol or drugs concurrently. This same reporting period revealed that up to 110,000 deaths occurred as a direct result of substance use disorder in the United States in 2022. And the cost of substance use disorder to the US population and to our communities is well over 800 billion. And this is made up of direct medical costs, lost productivity, as well as other societal issues like incarceration, justice system costs, separation from families, and accidents. So, does everybody who has a drink with dinner have substance use disorder? No, right? The answer is no, and that's why we have criteria. So, for a person to be diagnosed with substance use disorder, we want to see at least 2 out of these 4 criteria. We want to see impaired control, where the individual is unable to control their use of that substance. So you find excessive use. So for alcohol, which is the commonest, I'm going to give you numbers. Anybody who drinks more than 5 drinks at any occasion, for men, is using excessive. And for women, 4 drinks at any occasion is excessive. Any drink beyond 4 is excessive, okay?
That's a topic right there. That's interesting. Okay, I think someone else that can say that I drink 10, 12 beer. Hey! Yeah.
And that is the upper limit, okay? Because the dietary recommendation, so if you are a Weight Watcher, you're checking your calories, the dietary recommendation will be not more than 2 drinks for men and not more than 1 drink for women in 24 hours. So it's easy to cross that threshold, and you need to look into that behavior. So there is also the strong desire to quit or cut back on the use of the substance. And for functional impairment as a result of that use, so people are not able to meet their obligations in social settings, occupational settings, and other responsible roles. There's risky use. The commonest will be drunk driving. So people who know that getting on the road is difficult, is dangerous because of other road users, because of your own self and your impairment, but they disregard that because they are impaired. So that's a sign that substance use disorder is happening. So drunk driving is big. And also continuing to use despite knowing of a medical condition or psychological condition. For instance, there are people who continue to smoke tobacco or use tobacco despite having chest problems and lung problems, or even cancer. Along also with people who have liver problems as a result of alcohol use and they continue to drink. So these are all signs of substance use disorder. And last but not least, we have physical dependence, where a person finds that they need more of the substance for the same effect. So let's say last week you got a buzz from 2 drinks, and then today 2 drinks is not doing it for you anymore. You need to go up to 3. That's a sign that you need to find some help. So risk factors for the condition. Generally, risk factors are classified as genetic risk factors and environmental risk factors. So genetic risk factors in this condition, in substance use disorder, will account for between 50 and 60% of the illness. It's a complex mix of genetic and environmental factors. But like Dr. Sam was saying earlier, mental illness is not caused by moral issues or our weakness. You know, people who end up with substance use disorder usually have a genetic predisposition. So the best way to manage it will be to prevent exposure. Okay? So exposure is an environmental risk factor. It means trying your best not to surround yourself with substances that can cause problems and dependence. Also, co-occurring mental health conditions like depression, anxiety, and PTSD can draw a person towards substance use for relief. But the really difficult thing about that is that sometimes it's a vicious cycle where people start off with substances and then end up with these conditions. Again, because of genetic predisposition. Sam said, that not every, like some people, there's a myth that people say it can't happen to me, but what we find is that 2 individuals can set off doing the same thing, but one person who has the genetic predisposition ends up with the disorder, while the other one doesn't. But we don't know who until they get exposed. So minimizing exposure is key. Personal trauma, people who have experienced trauma, who have PTSD, they want relief, they can hold on to substances. And access to drugs and socioeconomic factors. So, poverty is a known example of that, where people don't have access to healthcare, so they end up using whatever they want to use. The same thing happens with obesity. The socioeconomic factors can drive up the incidence in certain communities. So what do? We try to limit exposure once again, because we don't know who is genetically predisposed. So, if you have a party, we watch, we don't allow people to misuse alcohol or drugs. It's our responsibility to help minimize exposure. So, depending on your age, depending on our age, we may recognize some of these individuals. And one thing they all have in common is that they are celebrities that we love or loved. They all died as a result of overdose of substances. And they all died at a point in their lives when their careers were peaked and they had so much more to give to the world. So that's the loss of productivity that we talked about. This slide exemplifies that. So you have Whitney Houston here, who died at the age of 48 in 2012, and cocaine was implicated in her death. And the autopsy report also showed other substances. Next, you have Prince, who is a Minnesota favorite, the native of Minnesota, who unfortunately died in 2016, and illicit fentanyl was implicated in his death. Next is Matthew Perry from Friends, great actor, died most recently in 2023, and ketamine was implicated in the center. We have Amy Winehouse, great performer, great artist, great musician, who died at 27, and alcohol was implicated in her death. And you wonder when she began to drink alcohol because of how young she was at that time. And that, we know that exposure at an early age worsens the prognosis and makes treatment more difficult and makes the condition more severe. And last but not least over there is my personal favorite, Michael Jackson, who died at the age of 50. And propofol was implicated in his death. So I know that this is a mixed audience. There are providers here, healthcare providers, as well as lay audience. And some of us here have never heard of propofol or even ketamine. What does that mean? It means that these people had great access to substances. And in the case of Michael Jackson and Matthew Perry, they obtained these substances from their providers. So healthcare providers enabled their use and resulted in their death. The Michael Jackson's personal physician has served his time because he was convicted of involuntary manslaughter. And two physicians have also been charged in the death of Matthew Perry. So my point here is that not just because it's legal or you're getting it from your doctor makes it safe. You still need to look out for yourself. You still need to look out for your loved ones and your friends because they can get drugs from every source. They can get substances from every source. It can cause problems. And also, we talk about substance use disorder and we think about poverty, like on the other slide, but these guys had access. These guys were favored and successful. So I will use this to transition to assessment and screening. We want to do the best we can for people who are around us. Okay, so if you have a friend who you think might be abusing a substance or misusing a substance, you can do some initial screening, and if you identify a problem, you can have them see their primary care provider who knows what to do. They can do more screening and find treatment, do an assessment, find treatment for the individual. So this is a slide about cage questions, which is a very good screening tool. If the providers here are not using cage questions for their visits, I will encourage them to incorporate this in their practice. And everybody can actually use it. But the providers for sure need to ask questions about these when they meet people. So cut down is based on a question that goes like this. Have you ever thought that you ought to cut down on your drinking or drug use? So have you ever thought that you should cut down on your drinking or drug use? Next is annoyed. Have you ever been annoyed by the criticism of others of your drug use or your drinking? So have others ever annoyed you? Have other people ever annoyed you by criticizing your drinking or your drug use? Okay. Next is guilty. Have you ever felt bad or guilty about your drinking or drug use? Again, have you ever felt bad or guilty about your drinking or drug use? And last but not least is the eye-opener question, and it goes like this. Have you ever had a drink or used drugs first thing in the morning to steady your nerves or to overcome a hangover? Have you ever used alcohol or drugs first thing in the morning to steady your nerves or to do away with a hangover? So these are simple questions, and I don't need answers, but these questions can help identify a problem, and there can be an intervention. So, like Sam said, for mental illness in general, of which substance use disorder is one, the early interventions help. When we catch people when the severity of substance use disorder is still mild, it's much easier to manage than when they are already far gone and they have a severe illness. The treatment will depend on the severity. So some people may need to be hospitalized, first of all, for detox, and then they may have to go to a residential treatment center and then continue maintenance with their clinics in the community. So the earlier we can catch a person with substance use disorder, the more we can help them. So this is about the treatment. So treatment of substance use disorder, like I said, has to do with the severity. When patients or individuals have mild substance use disorder, it is adequate to treat them by therapy, so psychotherapy. The goal of psychotherapy would be to help them move along on the stages of change. So some people are unaware, completely unaware of their substance use, and that's where we can help them by helping them to become aware of it. We call that the pre-contemplation state. In that state, they don't even know that they're doing anything wrong. So with therapy, when it's identified, we can help them to move along to the contemplative state where they are aware of it, but still not ready to make a change. Okay? And again, with therapy, we can move them along from that stage to the preparation stage where they are fully aware and they are now gathering the information they need. They are, weighing the benefits and the risks, the pros and cons of their behavior, and they are getting ready to go on to the next step, which is the action step. In that state, they have decided to seek treatment. So they are talking to their doctors, they are talking to a therapist, and they are making the changes that they need. And substance use disorder is treatable, 100%. However, the individual buy-in is the driver of care. So if a patient is still in the pre-contemplative state, if the patient is still in the pre-contemplative state and they're not ready to make any change, nobody can help them. But with therapy, like I said, they move along and they get to the point where they are ready to take action and they can be helped. And once they have started to take action and they are doing good, then we are doing maintenance, and that's where even the support groups help, NA, AA, SMART, all those help. Having good social support, minimizing exposure still, all the things we talked about earlier will help. And from there, in some cases, there could be relapse, which is a normal thing with substance use disorder. Patients can go through the whole cycle, they can have a lapse or a relapse, and with good help and with good support, they spring right back into the desirable area of sobriety. So the take home from this talk is that there is help available, recovery is possible, and that's the goal of treatment. In my experience, which is almost 20 years now, I've seen a lot of people who have recovered and done well, both from mental health problems in general, like depression, anxiety, PTSD, and also substance use disorder. So we talked about therapy, and along with therapy, there is medication management. So the common medication which is available would be Suboxone or methadone for opioid use disorder. Some people, some not, some people are aware of these treatments, but not everybody is aware. So rather than have a loved one die on the street, you can have them get into their doctor's office and get some medication to help them with what we call harm reduction. Also, there is the gabapentin, there is topiramate, there is acamprosate, there is antabuse for alcohol. These drugs can help limit cravings for drugs and alcohol, including naltrexone. Okay, and doctors can prescribe and manage individuals with these conditions. And last but not least, this is TMS, and TMS has been found to be helpful in managing mental illness in general and substance use disorders as well in individuals with severe and persistent mental illness and substance use disorder. We call those people mostly, we say dual diagnosis. Some of us have heard about dual diagnosis, and those people who respond to a combination of these treatments. So I was told that I have 5 minutes to go, and I'm almost at the end, so I'll just quickly go through the conclusion. It's self-explanatory, but the big takeaway here is that substance use disorder is a medical condition, it's a mental illness, it's treatable, and recovery is possible. Okay? It's not a moral defect. Dr. Sam already said that. No one chooses to develop substance use disorder. It's genetic predisposition, environmental factors, the interplay, and where we have it. Some people have underlying mental illness. Relapse is a common feature of recovery and substance use disorder. Just because a substance is legal or obtained from a physician doesn't make it safe. Okay? And I will go on to the next question. Next slide here, where you have my contact, as well as I'm open to questions at this point. So that's.
So because of time, we're only going to take 2 questions, and then we're going to move to our next presenter.
We can take questions at the end.
Awesome. Yes. Correct. And then also at lunchtime, you can reach out to the presenters and ask them questions.
Okay, thank you very much.
You can take 2 questions. 2 questions. Questions, anyone?
Hi, so my name is Edrin, and my question is, a lot of times when it comes to substance use, people don't really see food as a substance use disorder. There's a lot of people who seek comfort in eating and then develop health issues. So do you think that that is considered a substance use disorder, or how would you consider that?
So that's a good question. And the simple answer is that the DSM, which is the Diagnostic and Statistical Manual of Mental Illness, categorizes mental illnesses, and there is this unique classification for food addiction, which is the eating disorder. So that's why we don't really put it on substance use disorder. Yeah. But the whole mechanism is the same. It's inability to control your relationship with these substances.
One more question?
Thank you.
I'll be introducing our last speaker for the day, Dr. Vivian Bala Suarez, faculty LP. She's going to be discussing the strategies for healing and building community strength, talking about trauma and resilience in the community. Dr. Vivian Bala Suarez is a licensed psychologist and co-owner of Vima Integrated Wellness and Consulting Services, LLC, as well as Aspire Network, a nonprofit organization based in Crystal, Minnesota. Her practice serves individuals across the lifespan, beginning as young as age 2, providing mental health therapy and psychological assessment for ADHD, autism, and various mental health conditions. She also conducts evaluations for the U.S. Citizen and Naturalization Medical Waiver. Dr. Bala Suarez is committed to training the next generation of providers and supervisors, practicum students, and interns in psychology, social work, and nurse practitioner programs from various universities. She also serves as an associate professor in the psychology department at St. Mary's University of Minnesota. A devoted wife and mother of 2, she enjoys spending time with her extended family, gardening, cooking, dancing, and reading. We will welcome Dr. Suarez.
So I'm going to delve into the presentation in the interest of time. I am excited to be here today. Welcome to all, the organizers of this occasion. So we see the objectives. The goal today is to talk a little bit about more of educating, our communities about mental health, but specifically today I'll talk about trauma. I'll talk about the intersectionality between, the mental health, trauma, stigma, and then a culture and a religious piece. So just, providing education, understanding of trauma, and then, going on from there. Okay. So what is trauma? Trauma is what the individual say it is, right? And so the reason why that's important to note is that we all have different experiences. We all might be exposed to negative experiences, but what's important to note is that we take in information differently. And because our body takes in information differently, what is bothersome to one person might not be bothersome to another person. And so we see different kinds of trauma that we go through. Bullying. I put bullying over there first because our children in schools today struggle a lot. And as a result of bullying, we have children going on to develop anxiety, depression, trauma, low self-esteem, impacting their life sometimes into adulthood. So it's very important that we listen to our children's complaints about what they're going through and be able to seek the right support for them. And then we have for some of us who were victims of war, we have people who are emotionally abused, physically abused. So there's different kinds of trauma that you can become familiar with and know that, again, we all take in information differently. If someone today experienced a physical abuse and may not develop trauma symptoms, what we say post-traumatic stress symptoms. However, another person who might experience physical abuse might react so much so that that they go ahead to seek treatment. Okay, so let's go to the next slide here. Different categories of trauma. Sometimes people have acute trauma. Acute trauma is experiencing a negative event, and then when that event or the response to that event, continues with that individual for a month or more, we call that acute trauma. And it can be anything can be acute. However, though, when that person seeks services as a result of that overwhelming feeling, and we talk about the different kinds of symptoms of trauma, when a person seeks a support, maybe going to a therapist or talking to a counselor, a social worker about that experience, most times we tend to dismiss it. Oh, that little thing, it's nothing. But always listen to an individual explain how they feel. Always listen to an individual explain their own experience. Try to stay out of it because you went through a situation and did not respond in a way, the next person is responding doesn't mean that it's nothing. It's not something that you take for granted. Believe what people tell you. And this is so important, especially for people who go through sexual abuse. Okay, people who go through sexual abuse, whether it's hidden under the table, whether it's put to the side, and when that individual experience abuse, sexual abuse, or any kind of abuse, and then we expect them to overcome it. That it happened last year, it happened 2 years ago. No, as long as that person has not gotten the help, or even if they go for help, and have not yet learned to overcome and live with that experience, to dismiss them is to do them a disservice. Okay, so what I'm saying here today, listen to people when they tell you the story. Do not put yourself in people's shoes, because everybody's different. And then we have chronic trauma. Some people experience trauma throughout their life. And the body absorbs all of those negative experiences. There's a book out there called The Body Keeps the Score. The Body Keeps the Score tells you about how our body is so crucial. We cannot separate the physical from the mental. Absolutely not. When you hear people talk about holistic, it's the integration of the body, the mind, the spirit, the soul. And we must understand that we can never separate our body from our emotions, because whatever emotional experience that we do have, or people around us observe, is so much so connected to our physical, right? It's so much so connected to our physical. And as a result of some of these experiences, people go to develop medical problems, whether it be hypertension, whether it be high cholesterol, autoimmune diseases, and all of that. And so never dismiss what? That interconnection is there and will always remain, because we cannot separate the emotion from the physical. Okay, and we have complex trauma. Complex trauma is so much so that people not only experience trauma over and over, but most times it begins in our developmental years. Childhood trauma. And when a kid is exposed to trauma, what we want to know is that as early as 6 months, that part of the brain, that memory portion of the brain, that hippocampus, begin to retain information. So even a 6 months old who is not able to speak, right? We have the pre-verbal trauma. You see some people who went through trauma early on in their lives, but because they were not at a speaking age at that time, they wouldn't be able to articulate that experience. However, they will exhibit trauma responses, and when they exhibit these trauma responses, sometimes we cannot identify, well, nothing happened to this child, nothing happened to this child. No, something did happen to that child, because we see all of the responses, and that kind of presents as anxiety, being on edge, hypervigilant, very irritable, and all of those things. So not just the adult, but paying attention to our children. Because even in adults, when adults experience trauma, more than one, one, one or two, or repeated trauma, it impacts our memory, okay? It impacts our hippocampus, and when that is impacted, sometimes people wouldn't be able to tell the full trauma story, okay? People wouldn't be able to tell the full trauma story. It's not that they're lying. It's the body defense mechanism to say, you know what, it's so painful. I can't bring that to the conscious right now. So it stays underlying, it stays in the subconscious until with treatment and proper intervention, that person may be able to bring those memories to the surface. But it does take time. Some people go through trauma therapy for 1 year, some people go for 2 years, some people go for 5 to 10 years. Okay, and that's the significance of how it impacts not just our emotional health, but our physical health. Okay. So again, when I talk about trauma responses, it's normal and it's expected. When an individual goes through trauma experience, negative experiences that equate to the diagnosis of post-traumatic stress disorder, the reaction is normal and expected. Some of us have trauma responses without knowing how to connect it. And that's real, it happens. Some of us, because of our busy lives and because we've learned to accept situation as it is in our lives, we don't even know, we can't even name those trauma unless someone asks a question and that causes you to dig deeper, okay? But trauma responses are normal and they are expected. We have different kinds of responses. We see someone not remembering, someone blaming themselves. Did I put myself in a situation to get hurt? No, you did not. Even if you put yourself in a situation, it does not give someone the right to hurt you, okay? So emotional numbing. Some people will not be able to, to feel, they just shut down, right? You see some people with flat affect, finding it difficult to laugh, to experience any kind of pleasure. You'll see some people just have very distorted view of the world, blaming themselves, intrusive thoughts. Whenever you're out there, you hear a bang, you have a vision like you're on edge. Whenever you're out there, and something's happening, you're looking around. Why? That is a defense mechanism. That is to say is that whatever that is happening to me now looks like what really impacted me, so I'm going to have to protect myself and stay defensive so that I am not faced with the same repercussion of the event that happened in the past. Some people avoid talking about it. Some people avoid things that remind them of what happened to them. And then you have angry outbursts. We have these outbursts. We have the kids with disruptive behaviors. And then you say, oh, this person is always angry. This person is just very touchy. Well, yes, we see those responses. But it's not just happening because that person wants to be touchy. Something may have happened to that person that caused them to be hyper alert, caused them to be jumpy. And if you have a loved one who's experienced having those experiences, it's always good to say, why don't you talk to someone? Talk to someone because no one has to go through that. Some people don't sleep. And to make it worse, when people have those nightmares and dreams of those things that happen, when you're not sleeping because you've been awakened to those nightmares and dreams. And then the impact of not sleeping just makes life really difficult, for people. Okay, so, a speaker before us talked about, different kinds of mental illness. All of these come along with post-traumatic stress disorder, the trauma we experience. So I'm not going to go through the list, but know that we've got staff here, we got other mental health agencies, even previous speaker, ask them, talk to them. These are all things that happen, and sometimes we'll say, oh, my stomach hurt, and you can say my stomach hurt, or you having headaches, repeat that unending headaches. You'll see that people are not interested, people just want to stay home, not really wanting to do much. All of these things come as a result, not just as independent of, as a mental health disorder like depression, anxiety, but it can be linked to trauma. So coping, we talked about the fight. Some people will fight and become aggressive when they're faced with a threatening situation. Some people will run. You see some people freeze. And they will say, well, why didn't this person leave that situation? If that person's trauma response is freeze, when something happened negative, they wouldn't move. They will not move. they will stay there and endure more and more, okay? And you have the corn, a new one that's added. For some people, because they don't want to muddy the water. They're afraid that if something happens, they'll be so impacted and their body wouldn't be able to take it much. So the people please, they accept people to take advantage of them because they don't want, any challenging situation. So going to the stigma, self-stigma, we internalize the negative stereotypes and attitudes to society at large, okay? And so when we internalize that impacts our ability to go seek help. It really affects our self-seeking behavior. So the question is, how can I still acknowledge my culture, values, norms, and beliefs, while also acknowledging my religion, but while also being realistic about what's going on in my life with me personally? All of those things, because we're human beings, we have different experiences in our lives. We go to religion, we go to we have our culture. We can separate them. We can respect and honor them while also being realistic of who we are as individuals, and how can we, as human beings, seek the support we need, knowing that we do not have to suffer, right? And that's the goal. You do not have to suffer. You do not have to sit there and go through these experiences alone. There are people out there to help, okay? And so I went over that a little bit, just kind of, the example of a sexual assault, and then a stigma. I will go ahead and move on to culture implications. Across all different cultures and social factors, we know that we believe the direct cause of post-traumatic stress disorder. When you have negative experiences and your body take it on, that's what it is, okay? And then one way in which culture affects mental illness is through how the clients describe the symptoms. We have tons of different symptoms, and we all exhibit different symptoms at different times. And certain racial and ethnic culture occur to certain beliefs also, okay? And sometimes those beliefs will discourage help-seeking behavior. Again, I will go back to say, honoring your culture, but also knowing that you can get help, whether within your culture, whether outside. But I say therapists are around, providers are around, mental health practitioners are around. Tap in, talk to them, because the goal here is for you to overcome and get relief from whatever you're experiencing, okay? So again, across different cultures, whether it be Asian or Hispanic, and for some of us who are immigrants, that pre-migration trauma, the trauma you experience in your home country before coming to the United States, that pre-migration trauma is huge in all of our communities. So the goal is to be able to acknowledge that as well. And then we talk about the role of culture in stigmatization. Culture relates to how we see everyday problems, okay? In popular mainstream, and the media has a huge hand in this. As soon as someone commits a crime, they go digging deeper, and then they say, oh, this person has mental illness. Shame on you, because having a mental illness is not equivalent to violence. It doesn't, everybody, having mental illness is not equivalent to violence. Because, and I think it's so important for us to know, because when someone commits a crime, whether in rage or whatever it is, when we go to mental illness, we do a big disservice to people who are struggling, okay? It is not the mental illness that cause people to commit crime. It doesn't mean that just how in the general population, people without mental illness commit crime. People with mental illness will commit crime, but that is not a be or what. It does not go together. So something you should know today, okay? And then we have different ways, especially whether in the Latinx culture, how people, some of the things that prevent people from seeking help is out there. And then in the Asian American culture, people will not want to talk about it, they hold it on, they don't want to let go, they don't want emotions to show. Those are all cultural beliefs, those are all cultural norms. So what can we do when we have these experiences? And the goal is to be able to seek help. All right, I have these discussion questions, you can go over it, see them as it is. In the interest of time, we will not answer this question. But what I want to say here today, what I want to say to our leaders of our various communities, what are immigrants? Stigma is not just in minority communities. Stigma is also in the majority of culture, our host culture. And because some people of the majority culture will not want to seek help because of what they learn from their family and how mental illness is or not. Mental illness is a spectrum. We all, as long as we're breathing, we have mental health. It is the degree of severity that causes one to seek service, okay? And so we are go here today and know that we all have mental health, okay? We all have mental health. And sometimes in our lives, our mental health gets worse. And we can sit down and manage it, we can seek help, okay? And so also not just our Liberian people, our African people, our everybody here. When you get sick, when you're struggling with any kind of condition, physical, medical, mental, seek help. Right. All the church goes there, okay? We go to church. I realize sometimes we forget about the interaction of faith and action that propels us to go to seek help. Yes. It doesn't work separate. Yes. You can have all the faith you want. You can go on all the church praying now. When you sit there and struggle, you're strong. When you ask questions, you're stronger. And when you seek help, you get knowledge, you get help, and you are one of the strongest.
Any questions for Dr. Soiree?
Third education. And my question is based on trauma. As you said, most of us have trauma. We came from war-torn Liberia, like for example, me around July 4th. I get really nervous when I get firecracker. Or what I want to say, I want to fall on the floor. But I know you discuss a lot of stuff like I have listened, but what can we do to help us with trauma? How can we, like, besides medication and all that, what can we really do to help us? Because most of us are going through traumatic experiences and we don't even know how to cope. So what can we do?
Okay, good. Great question. And so first of all, I just want to recognize your resilience. Even though you were exposed to and you're still living your life, you're still going through in spite of everything, but you still have these challenges that you just named. Those are trauma response. If you're still experiencing those same response as you did many years ago, you've got to get help. You've got to talk to someone. Therapy. We've got a lot of different organizations here. Go out there into the vendors. There are different organizations named. We have people from my organization you can ask. We will give you resources. Whether you come to us, whether you go out there, we want you to be able to get help. And the more, once you get help and begin to talk about these things, you will see the difference in how you respond and how you go through everyday life. So we do have resources here. Talk to one of us. We'll be able to provide that for you.
Thank you as well. One of the questions that just came up to my mind, as we all from different countries go through these things, I noticed that we talk to each other. And yes, we may need professional help, but I just want to also encourage, along with what you're saying, is that continue to talk to each other. And I think that's one of the resources that we have to help us, because people who went through something can sit there and talk and laugh and that can help. Yeah, so not keeping it in might be another way if that is.
And that's fine. That's also, yes, it is good to have that support network, someone who can bounce things up. What happened in that situation is that, especially if you're not experiencing trauma, when someone comes to you and talks to you about that own traumatic experiences, it elevates your response. It elevates your trauma. So it's like they're telling you their own story. Because trauma is not just direct, it's indirect. We can become vicariously traumatized by people's story. So when someone tells you their story, you will take it in because they're your friend. But It will add on to your own experiences. So it's good to talk. It's good to have the social network, social support. But what I will say is that it's also good again to go to get help from the professionals.
We'll do one more question and then that's it. We're gonna wrap up and go to lunch. One more question? Okay.
So I don't have a, somebody else
I see your question back here. You?
Yeah, but as far as the president said, thanks for your presentation. Yeah, in your presentation, you mentioned that mental health shouldn't lead us in violence or committing some criminal acts. Okay, with that, people are using mental health to somehow reduce their crime they committed to some extent. With that, what is some of that? What are the additional recommendations you give in order to discourage or encourage people to come forward?
Come forward to what?
I mean, to expressing that they have mental health without going to commit crime.
Okay, so that's a tricky one because if someone is scheming and to get out of legal trouble, that's a whole new thing. That's why they have evaluators to be able to evaluate these individuals to determine whether they really do have mental health condition or whether mental health the severity of the mental health play a role in the crime, right? Someone can kind of say insanity as a result or the crime was committed because I was had a blip of a period of insanity. I wasn't thinking, but again, that's a determination for a forensic psychologist and to make, because people will be what they want to be. People will use, mental illness, for so many reasons. But if you go to a trained provider, that person will be able to conduct an assessment and determine whether this person, is severely mentally ill, as you're saying, or not. And so that's one thing.
Let me add one more thing to it. Mental health does not mean that you're not operating within your own mind.
Right. Yep.
So that stigma must be broken. It does not mean that you don't operate within your own mind.
Okay, thank you.
Hello, everybody. Thank you so much for your patience. Just want to remind all of you that blood pressure screening is the two most best when you get out there to do. And then don't forget immunization. We have the MMR vaccination. We also have the flu vaccine and the COVID vaccine. And it's all free. Mental health screening too. It's private. It's actually, nobody's going to say anything about you to anybody because these are providers and they're ready to respect your privacy for HIPAA. And I also want to let you know that we have food going to take an hour break and go in the gym for food and you can come back. We'll have the panelists here and Dr. Odin will be here. We have Dr. Joseph Howard and so many other panelists will be having more discussions. So we take an hour break, please. Thank you.
So we are going to take a break and we will be right back. We will be right back for section 2. These are all our professionals. They are here in the building. So we are. So we are taking a break and we will be back for section 2. Stay tuned and come back later. Talk to you guys later. We see you in a bit. It's lunchtime.